our local menopause, we call them champions. So the menopause provider for our hospital to help out anyone who has more complex cases. And thanks again for letting us be here tonight.
All right, so today we're gonna spend the evening talking about what to expect when you're expecting menopause. So first I want to just open with stating that this is not your mother's menopause. Not to say that your symptoms may not be like your mom's, because it turns out that in fact, when a woman undergoes menopause, a lot of their symptoms are very similar to her mom's. But what's different now is really the social discourse. So in the past, this topic wasn't really talked about openly. When it happened to women, particularly women in their midlife, it seemed like it was like socially irrelevant, just it was considered either a disease about failing ovaries, or it was just not important. So women often got dismissed with statements like, it's just part of being a woman, it's not that bad, just get over it. And this absence of menopause in our discourse has left some women feeling confused or even worried and possibly even lonely, because there aren't stories and culture that can provide comfort. But what we're seeing now is that our generation now finally wants to talk about menopause. So I think that's why we were actually asked to speak about this today. Many more women are now talking openly about menopause. Women want to be empowered with more information about trying to understand why and how their bodies are changing, want more data, want more good research to be able to inform decisions about their health. Some very prominent women have made some public statements, which I'll share with you here. So media mogul Oprah Winfrey stated, "I thought I was going to die every night." Around the time she started experiencing menopause, Winfrey explained that she began to feel listless and unable to focus long enough to read, a symptom that Winfrey says caused her to end the Oprah's book club. U.S. women's soccer legend Abby Wambach stated, "It's so wild to me that many of us will experience symptoms of menopause that can dramatically affect our life for up to 20 years, but so few of us know about what's happening to us. And what we want to do to improve our quality of life." And then First Lady Michelle Obama said, "There is not a lot of conversation about menopause. I'm going through it, and I know my friends are going through it, and information is sparse." So today we're hoping that we can close this gap to provide more information. So topics we're going to cover tonight, first, just defining what is menopause and what is perimenopause. We'll get into the natural hormone transition of what's going on and really why we don't test hormones. We'll talk about some common symptoms, then go through some other natural body changes that occur during this time in one's life. Then we'll dig into therapy, both hormonal therapy as well as non-prescription treatments, and then open it up to you all for some question and answer. So definitions. Menopause. Interestingly, you don't even know you're in menopause until a year later, because it's really defined by having 1 month of no period. The average age of menopause is around 51 to 52, and 90% of women will have been fully menopausal by age 55. And as I mentioned before, symptoms are very similar to your family members. There is a confusing other word that I wanted to talk about, which is perimenopause. And that's defined as around menopause. This time frame isn't defined by a certain number of months or years, but really just loosely the time frame for which you start having symptoms and physiologic changes that mark the start, and then that can go on through that year after the last period. On average, it's about 4 years, but it could vary in terms of time. And symptoms can go on for quite a bit. And then finally, the type of symptom, the severity, the timing, all is highly variable. So I'm showing this graph just to give you a sense of what's going on with natural hormone levels. What I want you to know is first is on the far left, we see premenopause. So this is what's going on in a woman's life during her 20s and mid 40s. And as I hope you can appreciate, there's a very predictable, hormones go up and then they go down and then they go up and they go down. And this happens once a month. And this is what drives the natural menstrual cycle, where you ovulate once a month and you have a period shortly thereafter. It's really predictable. On the far right, you'll see the postmenopause. And as I hope you can notice that, these hormone levels no longer have that once a month cyclic up and down, but just start to have a steady state where they're pretty even. And what one might think if they didn't see this graph was that you've got your hormone levels when you're, say, in your 20s, and you've got your hormone levels, say, when you're 60. And erroneously, you might think, okay, they just like come down, linearly. But in fact, that doesn't happen. So you can see in that middle section of the graph, this is what's going on with perimenopause. In the mid 40s to mid 50s, there's a lot of variation and volatility with the levels of hormones. And that variation can not only be, say, month to month, but really minute to minute, hour to hour. The ups and downs can swing pretty wide. And because of this volatility in the hormone level with any, say, minute or hour, it doesn't make a lot of sense to do hormone testing, because getting a single snapshot when you go down to the lab and get your blood drawn is not going to be meaningful, because an hour later that hormone level might be different. Your hormone levels in the morning might be different than the evening, and it doesn't really inform proving that you're perimenopausal or informing how we're going to think about treatment. So kind of the bottom line with this graph is that hormone levels are really, there's a wide variation, and testing doesn't make a lot of sense. So the reason why we don't check hormones, just to kind of say again, and this is corroborated by really prominent national organizations, the American College of Obstetrics and Gynecology, as well as the North American Menopause Society, make a lot of statements about how there is really no clinical benefit for measuring hormones. We know that they fluctuate. And as I just mentioned, in the perimenopausal time, those fluctuations can be really extreme. And the normal range is wide. So even though you have a quote unquote normal level, that doesn't disprove or prove that you're perimenopausal. You may still have symptoms, you may still benefit from treatment, even though that blood test result might suggest a normal. And there's also no correlation with the level of your hormones and what we might use for treatment, because your symptoms don't necessarily correlate with that level. So again, we're not really trying to treat a number. The way that we think about hormones, or I should say just treatment in general, is to alleviate symptoms. We want to treat the person, not a certain number or a certain blood value. One thing though is that an exception to that is if one stops having a period before 40, that's younger than expected. And there might be a reason to do hormone testing in that scenario, just because we're trying to rule out other causes for that cessation of menses. But otherwise, we try to avoid doing unnecessary testing. So what are the common symptoms of menopause? We're going to be throwing a poll in the chat to ask you if you've either currently or have ever had any of the following of these really common symptoms. So please participate in the poll, and we'll see what this audience is experiencing. But common symptoms we'll go through are menstrual cycle irregularities, hot flashes and night sweats, sleep disturbances or insomnia, mood swings, irritability, emotional changes, brain fog, fuzzy thinking, joint pain or stiffness, muscle soreness, vaginal dryness or discomfort with intercourse, or urinary changes like incontinence or urinary urge. So we'll just give it maybe a few more seconds to see what the audience is experiencing. So it looks like hot flashes certainly are the most common, which we see a lot. Brain fog and fuzzy thinking seems to be coming in as a tie for second. But as I'm seeing here is that all of these are common, and many women experience multiple of these. All right, so whoops, I'm going to just get that out of my view. So I'm going to just spend a minute on each of these symptoms just to kind of try to unpack what's going on. So menstrual cycle irregularities. As I mentioned, hormone levels are a little wacky right now. And because of that, the signaling to your ovaries to ovulate, and then therefore the resulting signaling to your uterus to have a period, is a little off. You might think that as you get closer to menopause, your periods would just like disappear into the sunset. But it turns out that it can be really erratic at first before they start to widen or lessen. So what we can see is that sometimes instead of what you might think is like less bleeding or less often, you might have more bleeding, more cramping, and consequently, the interval between the cycles can actually shorten. So it feels like you're having periods more often. So the kind of bottom line is that you might actually have either heavier, crampier, or more frequent periods until over time they start to become wider apart, usually lighter. One thing I do want to make a note of is that while it's very common to have all kinds of wacky, irregular bleeding, if you notice that you have bleeding, kind of spotting or bleeding in between what feels like your two normal periods, that is something you'd want to bring to the attention of your doctor. So if you're feeling like you're kind of either bleeding all the time or having spotting unexpectedly throughout the month, while that might be related to perimenopause, that is something that we'd want to evaluate. So definitely bring that to the attention of your doctor. Hot flashes. So what that's all about. So there's this theory that the lower levels of estrogen may cause the sensors in your brain to regulate your temperature a little differently. And what women feel when this happens is that you have this sudden sensation of warmth that often is in the chest and the face, but really could affect your whole body. These hot flashes can last for a few minutes, and some women it's just once in a while, but other women it could be multiple times a day. This affects about 80% of women. So it is a very, very common symptom, sometimes quite distressing and severe in about 10 to 15% of women, and about 20 to 30% go on to seek treatment. And this symptom can actually last a while. So it may start pretty intensely, kind of worse with perimenopause. And then even once you're menopausal, you can still continue to have hot flashes for several years, though usually they get to be less intense and less frequent over time. There are some things that can worsen the hot flashes, which can include tobacco, alcohol, caffeine, and anxiety or depression. And what we do know is that there is some ethnic variation to this. So African-American women often have more intense hot flashes, and the experience can last longer, even up to 10 years. Sleep. Many of my patients come to me talking about how when they get into their mid-40s, early 50s, their sleep is erratic, that they maybe have difficulty falling asleep, or they wake up earlier than they'd like to, having a challenging time, going back to sleep if they wake up in the middle of the night. Sometimes some of the typical menopausal symptoms can even further exacerbate sleep. The night sweats we talked about, and I'll in a moment talk about urinary frequency, but that can wake you up at night and then it's hard to fall back asleep. There's also issues where we'll talk in a moment about like fuzzy thinking or mood issues that if you don't get good sleep, then that can exacerbate your daytime experience. And then I'll also add that sometimes it's complicated because while some of this is driven by hormones, we have a lot of things going on in our life that can also affect our ability to sleep well, other life stressors, poor sleep hygiene, and just a lot of screen time. So it's usually multifactorial. Mood, emotion. So having mood swings, I hear my patients tell me that, they get angry for things that used to never bother them. Maybe they cry for no reason. They find themselves maybe feeling a little bit more down, maybe a little more depressed. And this can be something that can be caused by a variety of things. So there may be an emotion, a hormonal component, but also, having poor sleep that I just mentioned can also affect how you feel during the day. I'll also note that this is a time in one's life where there's just a lot of stressors. This is kind of a transition time for a lot of women where their kids might be leaving home. They might start to have to care for an older parent, maybe where they are in their career, especially if things change, can be really stressful. So again, this is a multifactorial issue that we see a lot at this time in a woman's life. That sense of feeling down can really start to lead toward a real diagnosis of depression. And we see that there is a significant increase in new onset depression during this transition, about 2.5 times more likely. And then thankfully, a lot of these kind of mood, emotional, and mood swings start to decrease once you're fully in menopause. I hear a lot of my patients just talking about the fuzzy thinking, the brain fog, the challenge with, say, word finding, or maybe the concentration isn't as good. Forgetfulness starts to creep up a little bit. And we think that there is some effect due to estrogen, though that exact correlation is still uncertain. There have been studies looking at estrogen levels in memory, and it turns out that women outperform men in terms of memory, but until menopause, and then it kind of evens out. So, something is there in terms of estrogen. And there are issues, as I talked about, with poor sleep that can also affect memory. All right, joints, pain, and stiffness. So this is something that can be actually quite common, where women report, just feeling more achy. And we're still understanding how estrogen hormones might be related to this. But in the Women's Health Initiative, the WHI study, which I'll talk about a little bit more in the future, that was a big study that had to do with hormone replacement therapy. Women who took hormones actually got relief. So that suggests that there is a correlation with the decrease in estrogen and the joint aching. So there are changes that happen in the bladder and vaginal area, and the medical term for this is called genitourinary syndrome of menopause, or GSM. I know that's a mouthful. It used to be called atrophic vaginitis, which is another mouthful. But I guess this is a term that we now use. So what's going on is that there is less estrogen that's getting exposed to this area. And with that comes less blood flow. And the tissue that makes up the vagina and the bladder area can be affected. The tissue usually just visually becomes a little bit more pale, likely due to the less circulation, sometimes thinner, more fragile. And so women, as a result, experience some vaginal dryness and sometimes irritation or itching once they become postmenopausal. And usually this is an issue that's more once you're into menopause, but can start a bit with perimenopause. Unlike hot flashes, which I said kind of dissipate as you get well into menopause, this is a condition that persists, and I would say often gets worse as one gets older. So the decreased estrogen affects all the organs in that area. So that includes the bladder, the urethra, vagina, clitoris, and labia. And because the tissue is thinner and more fragile, there's less moisture and lubrication, which can make penetration or sexual intercourse more painful. I'm feeling like that's kind of a depressing story, but we're going to talk about how to treat it. So urinary changes, I talked about, this area, which includes the bladder and the urethra. And with decreased estrogen and blood flow comes also decreased muscle tone, and that can lead to some urinary changes. So what some women experience includes bladder leaking, maybe when they sneeze and they cough or have a really strong urge to go to the bathroom, they sometimes will leak a little bit. That urge to go, like you gotta go when you feel that urge and run to the bathroom, that's also something that starts to increase as with older age. So I'm just gonna put out there, definitely do your Kegel exercises. Those are those pelvic floor muscle exercises to strengthen the area. And also note that it's not all about hormones, because pelvic muscle weakness can be due to other issues. And there are other risk factors that make one more prone to things like incontinence. So the older age, if you've ever been pregnant, had a vaginal delivery, if you're overweight, if you had a chronic cough, there's other things that put pressure on the pelvic muscles that can lead to urine bladder weakness, but know that the lack of estrogen can also contribute. So I want to talk just about a couple of symptoms that I hear my patients talk to me about all the time, but want to try to decouple these conditions with menopause in so much as the hormonal component, mainly because the corollary is if you think it's related to hormones, you think that if I take hormones, we're going to solve it. And that's unfortunately not the case. And those are weight gain, decreased libido, and skin wrinkles and dry skin and eyes and thinning hair. So word about weight. Many women tell me that, they're doing everything they can, they're exercising the same, they're eating healthy, but yet they can't seem to lose weight, or in fact, they're gaining weight. It turns out that on average, women gain about a pound a year between 45 to 55, as do men. So this is more about aging. And in midlife, how we deposit fat if we gain weight tends to be around the middle, around the belly. So, where you gain weight is also makes your body look a bit different. And there might be a change in metabolism. So you don't necessarily burn calories as well as you might have done when you were younger. It turns out that as we get older, we start to lose muscle mass. And our muscles are a tissue that just at rest burn a lot of calories. So if you have less muscles, you will be burning less calories. And that's called the basal metabolic rate. So if you have less muscles, you have a decrease in your basal metabolic rate. So you're not just burning calories when, just to maintain the physiology of your body. And it makes it easier to gain weight, and it makes it harder to lose weight. And it's not all about hormones, it has to do with just your muscle mass. There's also stress that can occur during this time in one's life, and that increases your cortisol, which increases your insulin, which increases your fat storage. And many women around this time, just because of the life changes that are occurring, may find themselves less active. They may not exercise or exercise in a way that can more effectively lead to weight loss. And then diets can also change. So, well, I absolutely recognize that this is a really common issue. Taking hormones is not going to solve it. Usually the most effective way is to tackle this with diet and exercise. Sexuality changes. So it's very common that I hear from my patients that they're feeling a decrease in their libido. So this is a little bit tangential. So things that are certainly related to menopause include vaginal dryness that can make sex uncomfortable. So if sex is painful, of course, you're not going to want to have sex. But there are other things that can affect your desire, which include, like I mentioned, those life changes that are happening at this time during the midlife, children leaving home, caring for the aging parents, career issues, body image concerns, because your bodies are changing, maybe depending on the maturity or any changes in your relationship. There's side effects from medications, stresses from our current modern life, all kinds of things can affect one's desire for sex. I hear a lot of my patients saying they're just too tired right now to have sex. So many women complain of this low libido during this time of life. And I wanted to just do this sidebar on sexual desire. So we're now just like taking a step away from menopause for a second. So libido, there are a handful of types of arousal, but the two that I'll highlight here is something called spontaneous arousal. So that's where you're just like ready to have sex, kind of want to have sex anytime, spontaneously. And then there's responsive arousal. So that is where you have a desire that's triggered. So you're kind of turned on because of a response to a stimuli. And that trigger can be a variety of things. It can be romance, date night, kissing, touching, foreplay. There have actually been studies looking on like on average, how much foreplay is needed for most women to be aroused. And it turns out it's about 20 minutes, which sounds like an eternity. It's a long time, 20 minutes. But know that that's normal. So a lack of this spontaneous, like I want to have sex, any minute now, all the time, that's actually not normal. I mean, I guess I should say it's not common. So there are some women who do experience this, but it's certainly not common. And so if you have a lack of spontaneous desire, that's not considered sexual dysfunction. That's not a disease that needs to be treated. It is actually normal and much more common to have this responsive desire. So once your partner shows some intimacy, romance, foreplay, once it kind of gets going, many women now are kind of in the mood, and that's normal. All right. Last thing is hair changes, wrinkles, due to lack of collagen, and that's a whole nother dermatology talk. But know that it's hormones, taking hormone therapy is not the trick to fix this. So that is part of aging. All right, so now we're going to start going into treatment, and I'm going to do some introductory remarks, and shortly after I'll turn the time over to my colleague, Dr. Hedley. But I just wanted to kind of introduce a few things first, and that is the history of hormone therapy. And I think many of you, it's kind of been in the news recently. So just the history of this is that prior to 2001, so about 20 plus years ago, we used the term HRT, hormone replacement therapy, and it was kind of given like water to women who were just of the right to age. By the time you're 50, okay, here's some HRT. It was thought to just be helpful for general well-being. The sort of indication was to replace hormones or to fix menopause. And then this big study came out in 2002. It was called the Women's Health Initiative. It was thousands of women were recruited, and a specific formulation of hormone replacement therapy was given compared to placebo. And that study, which I'll talk about a little bit more later, had a cohort of women, which included a lot of older women. So the average age of the participants in this study was actually 63, which is about 10 years past the time most women are in menopause. And these are older women who might be ones that could be more sick. But so it turned out that this study showed this increased risk of heart disease, blood clots, and breast cancer, which freaked everyone out. And the media really amplified these dangers. So because of this, HRT basically stopped being prescribed. The pendulum really swung to it being too dangerous to prescribe routinely. And then about 10 years later, researchers started to relook at the evidence that came out of that study, and also, just doing other studies, and new conclusions found that hormones were actually safe if we used it in women who actually would use hormone replacement therapy, because the time that we're really prescribing it is when women are having symptoms. And when I mentioned before is that perimenopause and early menopause are the time that these symptoms are most acute, and when women are really seeking treatment. And they're in their earlier 50s. So the data was kind of reanalyzed to narrow the group and look at like, well, what if we just looked at the outcomes of the women who took HRT between 50 and 59, so not the 60-year-olds. And what we found was that there was growing evidence, in fact, hormone replacement therapy was safer than we thought, because we were started to look at really the women where it made sense to do that. So now the data suggests that for most women, there's benefits of hormones that far outweigh the risks. And we're kind of moving away from this old idea that menopause is this unnatural state, like a disease we have to fix because of these failing ovaries. So now we're not trying to get hormones like back to normal, but we're recognizing that menopause is actually a normal and natural process. And sometimes hormones can be used to treat these bothersome symptoms due to that menopausal transition. So this is a graph that came out of that sort of re-evaluated data. So really just looking at the women who are 50 to 59, looking at the risks and benefits. So again, this is the WHI, that's the Women's Health Initiative. And you'll see these two graphs. So at the top, the graph is women who had hysterectomies. So they had no uteruses and therefore were able to take estrogen only. I want to focus the attention actually to the bottom graph, because this is most women with uteruses or uteri. These are women who did not have hysterectomy, and the type of HRT that's used in that case is an estrogen and progesterone combination. So you'll see there's like these red bars and there's the blue bars, and the red bars are the ones that resulted in some risk. But what I hope you can appreciate is there's this orange dotted line, and that orange line was sort of a agreed upon conclusion in medical circles that these are rare events. So that bar or that line is when that risk is less than 10 in 10,000. So the y-axis is out of 10,000 women. That's a lot of women, 10,000. How many increased cases might we see? And if it's less than 10 out of 10,000 women, it's rare. And you'll see that all these risks were less than that. So deep vein thrombosis, that's like a dangerous blood clot, was at 10, and you'll see pulmonary embolism is a blood clot in the lung. Coronary heart disease, you probably know stroke. Breast cancer gets a lot of airtime, and know that that's a risk of 6 out of 10,000. So that is, again, considered a low risk condition when it comes to being exposed to estrogen and progesterone. So said another way, is this, I mean, I'll just gloss over it in the interest of time, but this was actually taken from the British Menopause Society, knowing that, the Brits might have similar demographics as we have in the US. So this is kind of the takeaway. And basically saying that first group with all the blue women is 23 cases of breast cancer kind of in the general population. This is out of 1,000 women. And with HRT, there were those 4 additional ones, but you'll see other lifestyle things that people do, like drinking 2 drinks a day or smoking cigarettes, were kind of similar. And that second to last line, which is if you're overweight. In fact, that risk of additional breast cancer cases were 24 additional cases compared to the 4. So that just puts things in perspective, acknowledging that there is this increased risk, but it's not so high compared to some of the other things that we expose ourselves to. So kind of what does the data say? So as I mentioned, the WHI back in 2002, there are kind of 3 big things that people are revisiting. So one is the hormonal formulation. The type of HRT, the type of hormone replacement therapy that was used in that study was different. We don't tend to use that formulation anymore, and we have found that there are these safer ways to get estrogen and progesterone that are likely safer as it pertains to these risks, including breast cancer. There's also the timing hypothesis, which is what I stated about the age of the women that were studied. Because when you study older women, it just gets more complicated, because these are women that, as they get older, end up having more disease. But if we really look at the younger menopausal women, the ones who are actually going to be using this treatment because they're having symptoms, we are finding that these outcomes are much safer. And then also learning about how we get the estrogen, or how we take the estrogen. So in the WHI, it was a pill, an oral estrogen, and there is a safer formulation of oral estrogen, but we also have estrogen that comes in a patch form, a transdermal, like a sticker that you put on your skin. And that is also thought to be safer, that it could decrease the risk, particularly of stroke and blood clots. So what is hormone therapy? So HRT, hormone replacement therapy, has now been rebranded to HT, hormone therapy, because we're trying to really highlight that the purpose is not to replace hormones, but rather just kind of smooth out, even out those hormonal fluctuations. And the goal is to really alleviate symptoms. So it's most effective to alleviate the following, and the 2 asterisks are if we happen to use low dose birth control pills, because women in their later 40s who are having symptoms still have risk of getting pregnant. And so we often will use birth control pills to give them contraception and also manage the funny bleeding that they're having. And then the other things listed here are also treated by not only those low dose birth control pills, but just more traditional HT. So what hormone therapy is not is a silver bullet. So it's not really going to just make you generally healthier. We're really using it to alleviate symptoms. It's not a fountain of youth, and it doesn't have any direct treatment for some of those really typical concerning symptoms that I just talked about, like the weight gain and the decreased libido, skin wrinkles and hair loss. There might be some indirect effects, but it's not a direct treatment for those things. And it's generally safe. So now we know that we recommend using it in women under 60 within 10 years of menopause with their bothersome symptoms. We have some new formulations, which Shawna is going to get into. And as long as you're healthy and without contraindications, it's very fine. It's fine to take. And typically we use it for about 5 years, though we do individualize. This is in brief just about how birth control pills can be used as hormone treatment, just because birth control pills are a combination of estrogen and progesterone. So this is a way to get both of those hormones in. I'm going to skip through this because I already talked about it. And so I have two more to go. So for bioidentical hormones, so I want to just talk about this because I have a lot of patients coming to me asking about wanting bioidentical hormones. And it's just perplexing to me that it's so popular because it's not really a medical term. This is a term that's a marketing term that's kind of made up, but it's become widely popular, and it tends to be used when it is synonymous with custom compounded hormones. But if we really want to think of bioidentical, the definition would be hormones that have the same chemical and molecular structure as hormones that are produced in the body. I mean, that's what you would want, is something that is similar to what your body naturally makes. So it's bioidentical is not the same as just pounding it up in a compounding pharmacy. We're trying to get hormones that are similar to the physiology of our natural bodies. And there are many well-tested FDA-approved hormone therapy products that meet this definition. So estradiol is the name of the estrogen that our bodies naturally make, for which there are FDA-approved products. And micronized progesterone, there's a brand name that's called Prometrium that does the same. So the compounded hormones, again, not the bioidentical, even though people use them erroneously, kind of interchangeably, is really not recommended. It is absolutely not safer. It's not more effective. There is no science to support their use. The American College of OBGYNs and the North American Menopause Society do not recommend. And the reason is because, first of all, it's not regulated by the FDA. So there's no safety testing. If there are complications that occur due to its use, it's not reported. So we really don't have any evidence to support anything about it. It's not proven that the active ingredient is really absorbed appropriately. So we can't predict the levels that land up in our bodies. Sometimes it doesn't even contain what's supposed to be in there because, again, it's not regulated. So women are really taking this at their own risk. Sometimes the progesterone levels are too low, and we need progesterone to reduce the risk of uterine cancer. So if the progesterone is too low, you would now have an increased risk of uterine cancer. And then if the estrogen levels are too high, again, we can't control how much our bodies are absorbing. There is a possible risk of the uterine cancer as well as breast cancer. So definitely not recommended. Okay, I'm going to turn the time over to Dr. Hedley, who's going to get into more specifics about what hormone therapy is about.
All right, thank you, Pia. That was excellent. So I just kind of go over the slides and maybe a little bit about what options we have. So our current standard is when we use hormone therapy, most people's symptoms are best relieved by estradiol, which is the actual estrogen that our ovaries were making. So we have now mostly used estradiol, which is synthesized from plants, is where it's all sourced. So it's not from animals. Unlike in the past, we used Premarin, which actually stands for pregnant mare's urine, which was basically a product made from collecting the pee of pregnant horses in a bag and then drying it out and sticking it in a tablet, which had hundreds of different types of estrogens that our body was never meant to be exposed to. And that was also given as a tablet, whereas we mostly use our estradiol, if we can, through the skin, whether it's a cream or a patch, because that avoids most of the risk associated with estrogen. And the patch being preferred to oral, the main reason is it bypasses our liver. And by doing that, it doesn't stimulate clotting factors from being made, which are the things that result in the higher risk of a blood clot in our leg, which can be the more serious complication. And also oral tablets of estrase, which we do have an estradiol the plant-based form in a tablet as well, if somebody needs that. If you take that tablet, everyone absorbs it a little differently. Some people get a peak and a trough or a high level and a low level every single day. Some people it wears off in 8 hours and they still have hot flashes all night. So if you use a patch, you have a low, steady, constant level of estradiol in your system, which gives you much more kind of long-lasting relief throughout the day, and also hopefully helps, with the not only the hot flashes, but the sleep and the arthritis and preventing breast pain and bleeding and a lot of other things that estrogen can trigger, and headaches. Um, the most studied dose was a dose of 0.05 milligrams per day. That is what the patch dose. That's equivalent to 1 milligram if you do a tablet. So the doses aren't equivalent over time. We usually make sure a patient's on something similar, but it will have different numbers, which can get a little confusing. But the 0.05 is the one dose that is most studied in most of the research trials. So even though we have many other doses available, that's actually kind of the middle ground. We go as high as 0.1 and as low as 0.25. But this dose has shown no increased risk in stroke or blood clots. It doesn't affect our cholesterol or triglycerides, and it does reduce our risk of diabetes by as high as 30%. So there's some benefits of using it as well. And then just typically, if someone's going to use it, we try to make sure their, healthcare is up to, their pap smear is on track, their mammograms have been done, they've had their checkups, their blood pressure checked, their cholesterol drawn. Some things we need done first before we start it, just to make sure it's safe. Because if you remember from the contraindication slide, there were things on there that we can't use it, such as, God forbid, there's an early breast cancer that hasn't been detected yet, or, something else we need to know before we start a woman on hormone therapy. And then we do ask, every year or two that we see someone, do a, just touch base, mainly blood pressure and a breast exam, and go over how they're doing and see if there's any way, if they still need it, they're still getting relief. The average woman who's symptomatic will use hormone therapy for about 5 to 6 years. Then a lot of times as women get older, I find they just don't remember why they needed it, and they'll stop it or taper down and see if they do fine without it, since who wants to take a medication if they no longer need it? Next slide, please. And then we have to add, so the estrogen is for the hot flashes and most of the brain fog. There are some new studies out that it might help prevent Alzheimer's in people that have a genetic risk for that. The other things we look at estrogen for bone strength, sleep. We have to add progesterone back so that a woman does not get uterine cancer. Basically, the longer we take estrogen alone and the higher the dose, the more likely it is we see cancer. It's almost a linear path over time. So we really want people to take progesterone. And there's a lot of studies in Europe and the United States on the dose required and how many days of the month we need to take it. We mostly use, or we try to use, progesterone. It is equivalent to what our ovaries used to make. The company is Prometrium, and it's a progesterone in oil and a capsule. And the average dose is 100 milligrams. And I usually tell patients to take it every night because it does seem to restore our natural sleep pattern. It doesn't knock us out or put us to sleep, but it can help restore our natural dreams and sleep dreams and really help someone feel more rested as they sleep. And if someone can't use estrogen, they have studied higher doses. You have to go up to 300 milligrams usually, but that will also treat hot flashes and night sweats. Not quite as good as estrogen, but it was around 60% effective. And if a person doesn't have a uterus, they don't need to use progesterone, they can use estrogen alone, which if you remember the WHI slide, actually was associated with a decreased risk of a lot of the things, including a decreased risk of breast cancer. But some people without a uterus that have their ovaries do need progesterone, like people who've had a history of endometriosis. Sometimes we'll use them together depending on their reason for their hysterectomy in their past. But most women will just use, the average person will use estrogen and progesterone together. And it is a capsule. It's taken orally. You can use it vaginally if the oral dose gives you too many mood effects. And there's 2 routes. Sometimes we use it every night. That usually will make sure you don't bleed at all and protect you from bleeding. But if you're in that perimenopausal time where you're still getting your periods occasionally, since these are hormone therapy and not replacement therapy, you will still get your natural cycle and your period. And we don't want your bleeding to be erratic and unpredictable. So when you're in your transition, that first year or two around your last menstrual period, we will often recommend doing the progesterone 2 weeks out of the month, which will give you a light period every month most of the time. And there's other progestogens, because they're not progesterone, that are in birth control pills that are marketed for hormone therapy. There's quite a few of them out there. They're all mostly tablet form. So if someone doesn't tolerate progesterone, then we'll try a synthetic progestogen. And the most commonly used one is Provera, is the trade name, comes in different doses. And then there is something called a combi patch, which has a progestogen that absorbs through the skin. So sometimes that's easy to use and people prefer that. And then the Mirena IUD we use a lot for contraception, as an off-label use that we use a lot as hormone therapy in someone who doesn't want to have to take a capsule every night. They want to do their patch once a week, not be bothered. And if Mirena is what they prefer, then we can use it for that. And it's also a good bridge for contraception in our late 40s, early 50s, when there is still a very slight chance of pregnancy if someone needs contraception as well. And it's just a lot of people have heard the Mirena is good for up to 8 years. That's for birth control. When it's for hormone therapy, we really only do 5 years. And if you look at the blood levels over time, if you use it past 5 years, those progestogen levels start to drop, and we don't know if that still provides adequate protection from uterine cancer. So it is only actually recommended for 5 years. Next slide, please. And then vaginal estrogen, there is 3 different kinds we use vaginally. Then this is just local. So the hormone therapy for symptoms is usually not strong enough to actually fully treat vaginal dryness and irritation, or what we call GSM. So we have to use some estrogen locally, right where the receptors are for our skin that was there in our past, to make sure that we help this. So there's minimal absorption. The lowest dose is called Vagifem or Uvafem. It's a little tablet you use twice a week that's pre-measured. It's estradiol, so if it's bioidentical, if you want to use that term. So I usually use that first. And then the ring that you see in the top picture there, that's called Estring. That lasts 3 months. You should be able to place it and remove it yourself. It's something you don't have to think about. It's a little bit stronger, but still very, very low. If you measured estrogen levels, usually they're undetectable. And you do not, therefore, have to add progesterone with these because the dose is so low. And it can also be started in an older woman who maybe can't use hormone therapy, but they can use vaginal estrogen for vaginal issues. And then the estradiol vaginal cream is a cream. It's been around a long time. It's a little bit more absorbed, especially when you first use it. But if you stick to using just 0.5 gram twice a week, which is a very low dose, that 1 tube would last you almost a year. And you can use it comes with an applicator, and you could also use your finger and apply it to the vulvar tissues and then right inside, because sometimes the ring and the tablet don't treat the whole area. So some people prefer the cream because their dryness and irritation might be more right at the entrance or around the clitoris, and then actually vaginal estrogen cream would be a better option. And same thing, these have not shown to increase our risk of strokes, blood clots, or hormonal cancers, but the FDA requires the same package insert that goes with every single estrogen product that we make to be in this box. So even though it really doesn't pertain, I try to talk to people first and make sure you guys read that and get scared to let us know. But that's really shouldn't be in there, but the FDA requires that warnings be in there, even though it's not really part of this. And then just in case you run across it, there is something called FemRing, which is hormone therapy in a ring form that you wear vaginally that is much stronger and is estrogen therapy, but it's been off the market for a while just because of low demand. But recently saw some advertisements that maybe it's coming back on the market. Next slide, please. And then these are the top 3 are hormone-free options, because this is very common. About 50% of us have painful dry skin in different times in our life, but especially as we get into our 50s and into menopause, it gets more common. So you should always use a lubricant for any sexual activity, no matter what it is, basically just every time. So there's different types. Some people prefer water-based. We like the Good Clean Love company because they really try to keep a lot of other chemicals and preservatives out of their products. So that one listed is an aloe vera based water-based lubricant. There's many others you can get samples and try. And then silicone based are much longer lasting, much slipperier, and pretty affordable. And they just have silicone oil, so they don't have any things to preserve. The water-based need preservatives, which can sting and burn too. So silicone sometimes is better, but you just can't use silicone with any silicone toys. It will break them apart. They'll kind of peel apart like an onion. So and then it's extremely slippery, like in a bathtub. Silicone doesn't wash off. So if you use it in the bathroom, just be very careful. And then coconut oil is very popular to treat the skin. You can place it anywhere, it's very safe. People use to brush their teeth. It's a just over-the-counter cooking oil. If you keep it cool, it looks like a cream, and then you can use that as well for lubrication. It just, unless you're using condoms, it can break a condom. And then moisturizers are different. Those you use 2 to 3 times a week. The bad one. These are 3 of the more common companies. Is Replens is a water-based one. HyaloGYN is available online at hyalogyn.com. It stands for hyaluronic acid gel, which works as well as estrogen. It moisturizes the vagina, puts water back in the cells so they look plump and thicker, and it also acidifies the vagina, which helps fight infections. And there's quite a few companies out there making hyaluronic acid products now because it's so popular. This particular one is looks like a gel with an applicator, but they also make something called Reverie as a suppository, a little more expensive, but a little easier to use. And then again, coconut oil, if you use it 2-3 nights a week, it's a very good vaginal moisturizer. Not quite as good as estrogen, but very safe. A lot of my patients with breast cancer actually prefer that. And then the vulva, you can use coconut oil there as well, but these other products like V Magic is a company that makes a beeswax and botanical oil. It looks like basically like Vaseline. And you can buy it online through Amazon or a lot of places sell it now. But you just use a small amount, maybe every day before you go to bed or after showering, and it just protects your skin. Same as zinc oxide clear. It's designed as a vulvar barrier to protect our skin from our day-to-day activities, sweat, underwear, wiping with toilet paper. These things are very safe to use and can be very helpful. And then, as we talked in the previous slide, vaginal estrogen is prescription only, and these 3 products all use estradiol or bioidentical estrogen in different doses and are often about 80% effective. Next slide, please. And then there's a lot of non-pharmacological treatments. These are kind of a simple list. There's main thing is, avoiding triggers like hot drinks, hot tea. I know it's hard for me to have soup anymore. Big, thick, heavy blankets, a lot of layers. I have like 5 blankets. I change them. I usually use cotton and then wool. It's been a bit of work. Having a fan. You can get specialized cooled bedding. Like I haven't tried it myself, but they sell cool beds and they sell cool blankets and they sell cool pillows. They even sell ones that like we use in the intensive care unit that circulate chilled air, but those are incredibly expensive. And then if you wanted to do herbal supplements, unfortunately, there's for some reason a huge placebo effect with hot flashes with anything we try. So most studies show a 40% placebo effect when we study things that treat hot flashes. So we have to compare placebo to what we use to prove it actually is better than just feeling that you're taking something. So the herbs that are out there, black cohosh is marketed a lot, phytoestrogens, which are in soy products, evening primrose oil, dong quai, bee pollen, they're all around 40% effective, which is similar to placebo. Most of these are pretty safe. If you have a history of a female cancer, you should really not take herbs without talking to your oncologist, because a lot of these actually have some type of estrogen effects and are not okay. So we just want to make sure we know before somebody uses something. And then sleep-wise, melatonin has a little effect. Sleep specialists are currently not convinced, but it's over the counter now and can help some people. And valerian is from valerian root, which is where Valium originally came from, can have a little effect on sleep. And then there's also obviously sleep hygiene and all kinds of other ways to try to sleep better. And we haven't mentioned it, but sleep apnea actually has very similar effects to menopause. So I often have patients see a sleep specialist if typical things aren't helping, to see if there's something we're missing. And then mind-body approaches are also just reducing stress can reduce cortisol, and that will help our hot flashes get better. So mindfulness and yoga can help do that. Acupuncture, with how calming and soothing it is, and it's so safe to try. There are some more recent studies that cognitive behavioral therapy actually is effective. And that takes more time on your part, but we actually have in Marin cognitive behavioral therapy just for hot flashes has been initiated, and they just specifically focus on that, which actually, and hypnosis can work as well. The hard part with hypnosis is the studies had very strict definitions of what that was, and in the real world, you might not come across that. But again, it was safe to try if you have the time, and was more effective than a placebo. Next slide, please. And then more lifestyle stuff, just things overall that can help us feel better, even if even besides menopause. But healthy eating, doing more real foods, or what we macronutrients, just trying to get more plants and vegetables and beans and soy, real soy, organic soy, or soybeans, and not doing processed food, salt, sugar, gives you that high and a crash, which stimulates more endocrine changes that can actually make us feel crummy. And if we're overweight, we also have a lot more hot flashes. So if healthy eating, sleep hygiene, mainly making sure you keep your bedroom to be where you only sleep or have sex, nothing else happens in the bedroom, and trying not to be on your phone in the bedroom or with a bright screen. That's why reading a book is actually better. And there's a lot of free guidelines on sleep hygiene out there. And then exercise. Unfortunately, it didn't show it reduced hot flashes. You would think it would, because you learn how to sweat better and get heat out. But it is, it's good for us and will help us sleep better. So just finding something you like, otherwise we obviously won't do it. And I need to add it myself, but there was a recent review on building muscle mass, that we need to add weight training twice a week into our routine of whatever it is. Then they have shown that yoga puts a lot of weight and pressure on our bones and builds muscle, as well as lifting heavy weight. So just finding something that you like, or things where you lean against a wall and use your own body weight. There's a lot of stuff out there, but we need to try to add resistance training to our, or some type of weight bearing training to our routine. And then stress reduction. I think with COVID, this has really brought a lot of this to light. Cortisol, it goes up 20%, which causes insulin release, which turns into visceral fat, or that abdominal fat. And it could cause diabetes and trouble sleeping and a lot of hot flashes. So what we try to do is anything that reduces stress, which is these types of things: meditation, dance, reading, art, and connection. We have kind of isolated ourselves. If we can, try to get out and be a little more, or even just have someone over for dinner, or pick up the phone and when someone calls, just being a little more connected can actually make you more content and happier, which will reduce our stress levels. Next slide. Remember, takeaways. This is a natural process. We live almost half our life in menopause. Everyone will go through it differently. And it ranges from 2 to 7 years. Asian women, it's a little shorter, and women with African heritage a little longer. And then hormone therapy may be safe for managing symptoms, and just because you started doesn't mean you stay on it. There's many different doses, but you should only use it if you have a symptom that it might help. And is that all? Yeah, and there's non-hormone options as well, of course. Thank you. It's a question time.
Yeah.
We
So do you guys want to answer the questions from the chat, or do you need me to read it off, or what is best for you?
Maybe it would help if you could curate the questions.
Okay, why don't I'll start at the top when they started coming in.
Okay.
And some of these might have already been addressed. So you can tell me. Is HRT okay with IUD? I know that came up with the Marina, right? But I don't know if there's more. And they said they're on an IUD for heavy periods and going through perimenopause.
Yes, it's okay. If they're also having hot flashes and joint aches and other symptoms, and they could try a low dose, unless they have a health condition I don't know about, like a history of a heart attack, then they can't. But they can add hormone therapy to it. And if their bleeding isn't controlled with that Mirena, then we would talk about that as well and what else we could do to make that better.
Okay, and then the next one I see is if sex is not an issue, are there reasons, health reasons to keep to use estrogen cream to keep your vagina moist and pink, or is that just, is it okay, or can you accept that it's like that, or is there other reasons?
Do you want me to take that one, Pam, or do you?
Yeah, go ahead, Shawna.
Okay. It isn't like we don't like when I trained in the 90s, I did oh, you're 50, here's your hormone therapy. We tried to convince every single woman to take it forever. That was how I was taught. So now it's just, I do tell people, keep an eye out. These are the symptoms to look for. And if you start to feel them, let us know. But we don't tell every person that they have to use estrogen. It's
Okay. And they were saying, and so if you're dry, that's okay. If
it's dry and
comfortable.
bothering them, they could consider it. They could also try, moisturizer first and see if that's enough. And most of these moisturizers I noticed that are over the counter say, use me every night. You really need 2-3 times a week and be a lot cheaper. They just want to sell more. So, but usually using something every 2 or 3 nights a week will give a lot of relief.
And then somebody wants to know if there are any treatments that you would recommend for someone in their 60s. It seems a lot of the talk is about in their 50s.
Yeah.
Is there stuff?
Yeah. Well, if someone's within 10 years of their last period, like if someone didn't go to menopause till they were 56, they can still, it's 10 years from your last period or age 60, but there's some people that could start it later. And they could do also the hormone-free choices we use for, if someone has trouble sleeping and night sweats, the lifestyle stuff isn't working. There's a medication called gabapentin that can be really helpful and reduces hot flashes around 60% and also help you sleep. If it's daytime problems, a lot of the antidepressants in a really low dose balance the serotonin levels that seem to trigger these. So we often will go over those. And if someone has bladder control issues, there's a medicine called oxybutynin that we use for bladder that also works for hot flashes. So sometimes that combination is helpful. And then there's a new product that was FDA approved in May called Veoza, is the trade name, that just targets the center of our brain that triggers the hot flashes. It's an candy neuron receptor blocker, which are the neurons that cause these flashes in our part of our brain that controls our body temperature. And that seems to be about 80% effective. But unfortunately, since it's really new, we don't have a lot. We only have studies with a couple, maybe I think 1,000 women in it. We don't have a ton of data yet on long-term effectiveness on use in anyone with cancer. So, and it's very expensive. It's $20 a pill, which is the same as what Viagra cost. And the government actually recommended a much lower price and they didn't listen. So it's very frustrating, but it is, for some of my patients that are miserable and have failed everything, their insurance companies will often cover it to some degree. But there's a lot of choices out there besides estrogen.
And maybe I'll also just make the comment, it's not so much that there's like this magic number about 60, but as what we're trying to avoid is any other conditions that could just make estrogen use more dangerous, like the risk of cardiovascular disease, like the risk of stroke, and these things just crop up more as one gets older. So we do try to individualize.
Yeah.
Okay.
There's a cardiologist that works with us who is a specialty in menopause. She's amazing, but she said the cardiologists think as we age, estrogen used to be good for our blood vessels, and there's a point where the blood vessels are so fragile as we age, how we bruise easily and our skin is thin, that the estrogen actually makes that worse or sticks to the blood vessels and causes a clot to form. So it's probably part of the natural aging process, and there's a point where estrogen's just no longer helpful.
Okay. And then I think you kind of addressed this one, but does HT help with fatigue or brain fog? I know you brought that up, and they also said, or there's non-hormone treatment. Does it differ or is it better?
Brain fog is usually just perimenopausal, and if you can get through that first 2-3 years, most women it goes away. But estradiol works for the brain fog. It helps with focus and concentration. They have looked at people, who use it and don't, and women who use it do have a little better scores on those on memory tests and things like that.
Okay, and then there's a question about because this thing I know you addressed some of the diet, how your diet can impact your symptoms, but is there anything help with thinning hair? I mean, I know you talked about that before,
Yeah.
Pam, but you know, I don't know if that came up anymore. Is that just going to happen because we're getting older?
Yeah.
Yeah. Oh, so I guess these are two separate questions about the diet and the thinning
Mhm.
hair. And so most of the time it is frustrating because at least with the hair issue, there isn't anything that's going to crop up. But oftentimes when we first address this medically, there might be a panel of things that we may test for just to see you don't have a deficiency in something. I would say often it's all normal, so that's when it's frustrating. But we usually check an iron level. So sometimes iron supplements can be helpful, vitamin D. So I would say that sometimes supplements are relevant if there is a component that's causing the hair loss.
Okay.
And
then
we actually had a lecture from a hair specialist in our menopause group, and I realized I know nothing about hair. She spent an hour discussing, she had a 3-page list of health problems that can cause it. She does a full evaluation. She does recommend usually iron and vitamin D, says a lot of other supplements just don't do much. And then treatments, prescription treatments, depending on the reason. And she described it as just as we naturally age, the cells around our hair root that grow our hair start to die off. And so we still have the same amount of hair, it's just every hair is thinner. So it's like our forest of trees, all the trees are smaller. So that's why you can see your scalp more and why your ponytail is smaller. And then so thickening things, she talked a lot about conditioners and thickeners, things that are can give some relief, but actually it's whole own separate field. It's a lot that they can do. And sadly, there's almost no literature on estrogen and hair. That would be a good thing to look at.
Okay, and then you might have addressed this in the earlier one, but they're asking if you're already on the Mirena IUD, would you also take HT pills?
Just the estrogen part, yeah.
Oh,
Yeah.
so because the Mirena, it already has the progesterone in it, so you would take the estrogen part. Okay.
I
And
actually try to convince my patients, especially if they still need contraception, that it's kind of, in my opinion, like the most, like if you're trying not to take a pill every day, it's like the most elegant form of hormone therapy. You've got your IUD just lying there doing its work without you having to manage prescriptions or taking a pill. And then you've got your patch that you change out once a week. Also, not a daily burden because you don't have to deal with removing your patch every week. So many women who use their Mirena IUD as their contraceptive method. And as Shawna mentioned, last 5 years, maybe they're like 2 or 3 years into it, but now they're starting to have perimenopausal symptoms. They may not need their IUD for contraception anymore, for birth control, but it's just the added benefit if that's the progesterone component of your HT. So we can just like put on the patch and you're, automatically starting your HT kind of more easily. So I would definitely encourage it.
okay, and I think you had this on one of the slides, but they're just saying, what do you recommend for women who have ovaries removed?
Usually just estrogen alone.
Okay.
So they can get away, which is nice because sometimes progesterone has all the not fun side effects like sleepiness, dizziness, acne. There's some issues that not everyone tolerates progesterone.
Well, just to clarify the question about ovaries. So so there's the uterus and the ovaries, which are, different organs. So if you had just the uterus removed, but you still have your ovaries, that's one thing. And that's where we're saying estrogen alone would be helpful. You don't need to use progesterone to protect the uterus that you don't have anymore. If for some reason your ovaries were taken out, but you still have your uterus, actually, Shawna, maybe you should weigh in, but I would say you'd have to do both.
Then they have to do both. Yeah.
You still have your uterus then, which can be stimulated by the estrogen, which could increase your risk of uterine cancer.
Yeah.
And I would also say usually your ovaries are being removed because you had some medical condition that required that. And sometimes that happens before you're menopausal. So women who are, say, like 40 but need to have their ovaries removed for some other reason, we would actually recommend that they take estrogen because they're too young to be in menopause. So in some respect, we are trying to replace their hormones at that time because they're young.
Okay, and then will I don't know how to pronounce the whole thing. Can you see it in the Q&A supplement help? It's methane supplement?
I did. I think I looked that up once for a client, and if off the top of my head, I didn't have any proof it actually helped with menopause symptoms. I apologize. I don't know more than that. I'd have to research it.
Okay. And then they said non-prescription products like Kindra.
I don't know what that is actually. I
Okay.
haven't.
I actually Googled
Do you
that
know?
while you
Yeah.
were talking about Kindra, because I'm not familiar either.
Yeah.
It looks like it has a variety of oils, including coconut oil in it.
Is it
And some
just a
other kind of
topical?
moisturizing product like
Okay.
dimethical. It's topical.
Okay.
So I mean, it almost reads like a skin moisturizer because it's got like panthenol and other things, dimethicone. So it might be okay. We're just unfamiliar with it.
Yeah. And then somebody wants to know if can you combine the different vaginal dryness things
Yeah.
like lubricant with moisturizer, all those kind of things?
Absolutely.
Okay.
You should. I usually tell people to
Okay.
do a lubricant, an estrogen, and a moisturizer so that they're using something 3 to 4 nights a week.
Okay. And then is HT safe for women who take cholesterol medications, especially triglyceride medication?
That one's a little harder. I would do the patch, but that shouldn't affect the LDL, the HDL, or the total cholesterol. But if it's just for triglycerides, I would actually ask their doctor and make sure it shouldn't raise them, but I would ask first just to be sure it was okay. And oral I would avoid if it was triglycerides.
Right. That would increase your risk of cardiovascular disease, and we really want one's 10-year risk to be less than 5%. So I think we'd have to individualize.
Yeah. We look at age and blood pressure and smoking history and all, and gives us a score for someone's risk of heart disease to help us.
Yeah, we are recording it to one of the questions that just came up. And so we will put it on our the library's YouTube to go over because there was a lot of information for helpful people. And then one of the other panelists, or not panelists, one of the audience members said they, I guess from their own experience, Kinder's hot flash capsules don't really help, didn't help them anyways. So that was the share. So it looks like, does anybody else have any other questions? I know that was a lot of information, but very helpful to me anyways. Anything else? Is respiratory problems one symptoms? Would somebody like to know?
That's not a common menopausal symptom.
I haven't had anyone come to me with just that as the only symptom.
Shawna, I'm seeing the chat about addressing pellets.
Oh, I was wondering if we didn't bring it up at all.
Yeah.
So pellets are a little pellet of hormones that they will check your blood levels and try to customize it to you, and is very popular in South America. NAMS, which is the North American Menopause Society, and the International American Endocrine Society, and our College of OBGYN all don't recommend them. And it's not that I wish they worked. The hard part is they're just kind of like hormones crushed up into a little pellet that they stick under your skin. And unfortunately, they melt at a different rate for each person, and they can make your levels of hormones so extremely super physiologic or too high that you have all kinds of side effects. You can't take it out and you're stuck with it. I have one patient whose testosterone is extremely high over 2 years, and it just isn't coming down, and that can cause hair loss, high blood pressure, acne, voice changes. They just often are just way too strong. And if they could make one that was regulated to release the hormones at a constant, steady level, like the Mirena or the Nexplanon implant, things we use for contraception, if they could make one that did that at a level that was safe, that would be a great thing. But we just don't have it yet. So we don't recommend pellets. They're too unpredictable, and they can cause a lot of problems.
Okay, and then somebody wants to know, is it best to which doctor is better to approach for your menopause, your OB or your primary doctor?
your your OB
Your
gynecologist.
gynecologist.
Yeah, hopefully.
Although we're biased because we're gynecologists.
Some family practice doctors are good at, but unfortunately find they often use older fashioned. People often come in on really high doses and oral, and they're not really offered any of the nuances of lower doses and safer ways of giving it. But that's just my personal experience.
Okay. And then is HR stopped cold turkey, or can it be gradually reduced?
It can do either. So they did look at stopping cold turkey and then tapering, and they followed women over time. And at 6 months, both groups were at the exact same space with their symptoms. So I usually tell people they can taper down, and then I work with them and talk to them every month, or they can try cold turkey. It's going to be a little more sudden acute symptoms at first that would resolve quicker, but you would be, it just depends on what someone's more interested in doing, but both are okay.
Yeah. And I'll just add that it also probably depends on what dose they're starting at.
Yeah.
So if they're already on a pretty low dose, it may be
easier.
Pretty easy to do the cold turkey. But in my experience, most women, while they might in the end be the same, that transition is pretty uncomfortable. So I usually tend to recommend the weaning because it's more pleasant. If you just thought cold turkey and you were on a relative high dose, then the hot flashes you were trying to control could just like flare right back. So then you just don't feel as well. You might have to kind of suffer through it, and that's what we're trying to avoid. So I'm a fan of actually kind of like the slow wean. If a woman's willing to work with me and have some patience with it, I might drop her down, do like 4 weeks of that level, then go down again, and like another 4 weeks, and then finally off. Like not just one day of a change, but really 2 months of the change.
Yeah.
To get it down. Yeah.
Okay. Well, I thought it was really helpful, especially with all the everybody else's questions have kind of really informed me as well. So thank you, everybody. And like I said, we should be putting it up on our our YouTube channel, right? I think. If you have any questions, feel free to send me a message anyways. And I really appreciate Pam and Shawna sharing all their good information. Thanks, everybody.
Thank you. Thanks, everybody.
Thank you.
Okay.
My pleasure. Thanks for inviting us.
Okay,
Bye.
good night.
Good night.
Bye.